I'll straightway go to our topic today. The main source of autofluorescence is lipofuscin within the RPE. Due to incomplete breakdown of photoreceptor outer discs, there's a subsequent incomplete release of degraded material which leads to progressive lipofuscin buildup. Now, this excessive accumulation of lipofuscin in the RPE cells represent a common downstream pathogenic pathway in various hereditary and acquired retinal diseases. What we do is we try to initially examine the spectral properties of these fluorophores. It has been seen that they have a highest excitation spectrum around 480 to 510 nanometers, and they emit usually at 600 to 640 nanometers. Now, when these fluorophores are imaged, then the image that we have is basically fundus autofluorescence. It's a non-invasive method where there's topographical mapping of the fluorophores, especially lipofuscin, in the RPE monolayer, and it occurs with disease involving the outer retina. So this is a normal autofluorescence which increases with RPE dysfunction. So basically these are the increased autofluorescent areas, and it's decreased when there's loss of photoreceptors. Now, there can be various causes of reduced signals, like reduction of the RPE lipofuscin density, for example, in RPE atrophy, in hereditary retinal dystrophies, where there's increased RPE melanin content, like RPE hypertrophy, where there's absorption of the extracellular materials or cells or fluid, that is, there's fluid anterior to the RPE. An increased signal is seen when there's excessive RPE accumulation. Most commonly and most classically are the lipofuscinopathies, like Stargardt's disease, like Best's disease, like pattern dystrophy, and also in AMD. Again, where there's occurrence of fluorophores anterior or posterior to the RPE monolayer, like intracellular fluid, like when there's subpigment epithelial fluid and PED, like Drusen's. Also when there's a lack of absorbing material, when there's ONH Drusen, and of course artifacts. So the basic point that we should remember, the summary of it is, it's increased when there's RPE dysfunction, and it's decreased when there's loss of photoreceptors. Again, there are two ways of acquiring autofluorescent images, like one is the confocal scanning laser ophthalmoscope method, other is the fundus camera method. I will not go into the details or the differences between the two. I think we'll straightway go for clinical applications of autofluorescence, those that we face in our day-to-day life. We will start off with hereditary macular diseases. This is a 27-year-old lady who has a Stargardt's disease, fundus flavimaculatus spectrum. Autofluorescence shows a central oval area of reduced signal surrounded by small disseminated spots of reduced and increased intensity. Now, central RPE atrophy is present, which shows a decreased FAF intensity. At the periphery, the flecks correspond to punctate spots with bright autofluorescent signals. They are better delineated and the numbers appear to be greater in the FAF images rather than normal fundus photography. A 48-year-old gentleman who has an extensive multifocal retinal pigment epithelial atrophy due to severely decreased FAF signals. And the retinal periphery shows marked alteration of the normal background signals. Now let's come to Best. It's a 10-year-old boy, vision 6x6, red-free images show a well-defined white deposit centrally at the level of the RP. And when do we do FAF? We find an immensely increased signal that corresponds to this deposit. A 21-year-old gentleman, again, best macular dystrophy. Right eye shows vitello-eruptive stage where there's increased autofluorescence inside the central lesion, particularly at the bottom. And at the very center, there's decreased intensity, which proves that there's incipient RP atrophy here. Now, in the left eye, there's increased FAF at the borders of the lesion with a very bright signal at the bottom. The border is autofluorescent and a supposedly pseudo-hypopyon at the bottom. A 65-year-old lady, previous electrophysiology has shown a normal ERG with a pathological EOG but no light rise. The central area of RP atrophy is shown by the markedly decreased FAF signal and a second lesion at the superior macula in the vitello-eruptive stage showing a mottled increased autofluorescence signal. Retinitis pigmentosa, 23-year-old gentleman, vision 6/6, a parafoveal ring of increased FAF at the macula. And this ring constricts with time. X-linked retinoschisis, there's increased hyperautofluorescence corresponding to the area of the schisis, probably due to displacement of the luteal pigments. Now let's come to age-related macular degeneration. In Drusens, there's decreased FAF at the center of the Drusen, surrounded by an annulus of increased FAF. It might be due to the attenuated RPE at the center and tangential orientation of the RPE cells at the edge of the Drusen. Now, according to FAF characteristics, the pattern of Drusen deposition in patients can be classified. It has been classified as 1, homogeneous background, 2, where there's minimal change, 3, focal, where there are well-defined spots, 4, patchy, where there's large soft drusens, linear, like corresponding to the hyperpigmentation, and lace-like, where there are multiple branching linear structures, reticular and speckled. Now, why has this classification been done? This is still under study in various centers where it has been investigated if there's any specific high-risk characteristics of disease progression amongst these various types of drusens, and also to design and monitor future interventional trials. Molecular genetic analysis has also been planned and been carried out right now to identify one or several genes that are conferring risk of development in certain AMD manifestations. Now let's come to geographic atrophy. We all know that it's an atrophic late stage of dry AMD. Now, FAF usually, as expected, would be markedly reduced over the atrophic areas, and there's high intensity FAF at the junctional zone. Again, these patterns of geographic atrophy and the patterns of deposition of hyper-intense autofluorescence has been classified into several subtypes like none, focal, banded, patchy, and diffuse. Again, this diffuse has been subclassified. Now, this is a very interesting study that showed that when these subgroups had been analyzed over an 18-month period, there has been different progression, a different rate of progression of the atrophy. The highest rate being in the diffuse subtype trickling group, which shows that this progresses, the geographic atrophy progresses at a rate of 3.78 square millimeters per year. Now, this slide shows rate of progression of hyperautofluorescence. Let's look here. This area seems to be progressing over a period of 18 months. Now let's come to wet AMD. This patient, 6/18 vision, there's a fresh hemorrhage and subretinal fluid and also a PED. FAF shows the borders of the SRF, and it seems to be normal at the site of the active CNVM, suggesting that RP is still viable, which would, of course, corroborate with this vision. And angiography shows fibrovascular PED. Let's come to CSR now. An ink blot leakage that's imaged 2 months after the beginning of the symptoms, and there's minimal changes in the autofluorescence. 3 months later, the gravitating material in the subretinal space blocked the background choroidal fluorescence, and area of detachment is marked by a hyperfluorescent area here. 1 month later, there's increase in the autofluorescence because of accumulation of material in the outer retina. Again, the angiography shows the leakage. Even if we don't do the angiography, the point leakage is clearly delineated by the hyperautofluorescence. Now let's come to inflammatory disorders. This is Serpiginous Choroiditis, where it shows peripapillary choroidal atrophy, and there's, as expected, hypoautofluorescence corresponding to the choroidal atrophic areas. Now interestingly, when this patient was followed up later, an immensely hyperautofluorescent area was found at this area, which corroborated, which means that there is reactivation of a quiescent serpiginous lesion. So there are plenty of institutes nowadays who do not do an angiography in serpiginous choroiditis. They just follow the autofluorescent pattern so that the treatment and treat the patient, see how the autofluorescence is behaving, and accordingly taper their treatment. There has been a gradual shift from angiography to FAF to monitor the prognosis and the modified treatment accordingly, as I said. Recently, FAF imaging, it has been proposed that it may disclose distinct phenotypic variations in retinal dystrophies than in accordance with the histopathologic data, novel prognostic markers for disease progression and areas of subsequent visual loss in both the early and advanced AMD manifestations. In CNV, choroidal inflammatory conditions, central serous retinopathy, the RP integrity can be assessed, and fine detailed visual function testing with microperimetry demonstrate there's a functional correlate between that and autofluorescence findings. So to conclude, it's a valuable non-invasive tool in our armamentarium which has revolutionized ophthalmic imaging, and definitely in the near future it's going to contribute immensely to our understanding of pathophysiology and treatment of various retinal disorders. Thank you.